Thank you very much. First of all, thank you all for joining us. Yes, the question is timely, and it's a question that we conceived of when the book project came up and is before, obviously, the pandemic. Little did we know that it would become quite the burning question that it has. So I guess one way of introducing this is to tell the story a little bit how the book came to be. So several years ago, I was asked by the National Collaborating Center on Healthy Public Policy, which is a part of a series of collaborating centers funded by the Public Health Agency. I was asked to write a paper on essentially, why does the government not do what the evidence says the government should do? So from a public health perspective, this is quite a reasonable question to ask. From a political science perspective, or for those who work in government, it's a somewhat odd question. That is to say, it's not obvious that policy would in fact be based on the evidence. And as Catherine Smith, a professor at the University of Strathclyde, who has a chapter in the book, as Cat Smith has written, what makes you assume that scientific evidence does or even should be a driver of public policy? So the origins of the book then are a bit of a stalemate between two views. The one that assumes that, of course, policy generally and public health policy in particular will be driven by the evidence, and the perspective of those in political science and beyond, for whom the question is far from obvious. So the book we're launching today and the panel conversation is an attempt to try and bridge that stalemate, if you will, and offer some more nuanced perspectives on the role that scientific evidence does and does not play in policymaking. So I could go on and on, but I'll stop there. And
so thanks for this question, Vanessa and Patrick, for giving a bit of history around the book and how it came to be. I guess I would respond indicating that certainly science is one part, but not the only part or singular part of the policymaking process and of the evidence that's considered within the policy context. And in public health, I think what makes it so interesting is that public health, of course, has a really diverse and rich evidence base from which it draws. Public health isn't a single discipline, but is by its very nature interdisciplinary, which means we're drawing not on a single science, but rather sciences, and really trying to formulate that into cogent policy and science advice. Science, of course, can be used in multiple ways, and I look and my thinking draws a lot on Carol Weiss's work, which is old, but still so relevant around the many different ways in which policy is used, or in which science is used in policy. And of course, that applies to things like influencing thinking, or being used in a really direct or instrumental way, being used to justify a certain course of action or explain it. And I think that really is a very nuanced understanding of how knowledge moves within policy systems. I would say to your second part of your question, Vanessa, the role that it plays and whether it varies depends on level of government or otherwise. I guess I would say I think the role depends on whether or not the capacities exist to generate evidence, to synthesize it in a meaningful way, and to make meaning of it for the policy context into which it's entering. And certainly we're trying to do that well at the Public Health Agency of Canada. And from the chair where I sit, we look at it as well in terms of our scientific integrity work and really ensuring that the place of science within the policy cycle is not dependent on a given situation or given individual, but is really enabled through scientific integrity practices where scientific advice is incorporated as part of decision making.
Thank you, Sarah. I'm now going to turn to Carole.
Hi, everyone. Thank you for the invitation. I'm really glad to be able to attend this panel with you today. I'm not going to say anything much different than my colleagues have said already, but maybe I'll give you a case example. When we first started to think about the book back in 2018, 2019, From my point of view as a political scientist, I already held the view that science is one of the building blocks of making policies, but it's not the only one, and there's more to it. The thinking that we sometimes have is that people in public health tend to see evidence as the cornerstone on which policy is made, and maybe the only building block for making policy. So well, together with colleagues with whom I co-authored the chapter, we started thinking about this. Is it really what we observed in the case of making active transportation policies in Montreal and in Toronto? In this case study, we've actually come across senior public health actors, managers in the regional public health authorities, who were very, very knowledgeable about the policy process. And they were also very attached to their evidence, but they used their knowledge about the policy process to better integrate it into the other blocks, the other building blocks of the policy process. So for instance, they built a very strong evidence base why active transportation policies, municipal policies for active transportation could be really beneficial for people's health, but they did not stop there. They developed strategies to make sure that the evidence was actually circulated to policymakers. They took part in the official consultation processes. They gave presentations to NGOs and citizens to share data about injuries and urban design when walking or cycling. They worked together with civil servants from other sectors to give them supporting evidence about how to redesign bicycle lanes or sidewalks. They organized public conferences and invited local elected officials to those conferences to give them ideas about what happened elsewhere in the world. So they did all this to make sure that the evidence was really integrated into the other aspects of the policy process locally. So it's not that much of an opposition between evidence and science, but I think they found a way to reconcile both and to use both science and politics. And as to your question on does the role of evidence depend or vary depending on the order of government? I'll make a shout out to Evelyn Delou, who I think is in the audience. In her chapter in the book, she said, the local is better. Local is better because key actors are easier to identify. They know each other. There may be less barriers to actions, more opportunities to make agendas visible. So I think maybe that's what we witnessed in the case of active transportation policy, but also I think probably if we look at what happens on the federal level or the provincial level, some of the same processes are still valid and are still in existence. So is the role of evidence radically different at the local level? I'm not sure, but there's definitely something to it.
Thank you, Carole. So my next question is about the pandemic. And I'm wondering if you could each speak to how our collective experience with the COVID-19 pandemic has altered our understanding of the role of scientific evidence in the making of public health policy. I realize this is a big question. Who would like to get us started? Maybe Sarah this time?
I mean, I guess I'll start by saying what a ride. I don't know that there has ever been a time when more has been expected of science, when science has been more a part of the policy, political, public discourse than at this time. And I think a lot has been expected and demanded of science in the last few years that will alter the way that science is done going forward, for sure. I also think that a lot of innovation has erupted as a result of this time of extreme disruption. And so I think that we're also going to be in a really interesting time for deciding which of those innovations in how science is funded and conducted and used will be maintained when we emerge from this period. We have a couple of examples. The first is just around pace. And when you think about the case of vaccines, from the time that the virus was detected to the time that shots were in arms, how quickly that happened. Yet if you look to Bill and Melinda Gates Foundation and others, it wasn't fast enough. And we've got a 100 days challenge in front of us instead of a challenge that was many months long. We saw an explosion of preprints prior to peer review. I think that was a win in many ways in terms of making science more accessible and available sooner and in an open way. I think that we also saw a number of examples where there were changes in findings post peer review and once the articles actually made its way through the publication process. I would say the sheer volume of science has been absolutely staggering. I looked at the Dimensions database not long ago, and there have been over 1 million publications globally on COVID-19. That is just almost incomprehensible to imagine that volume. And so, how to make sense of that vast, very quickly developed evidence base is, I think, going to be a real challenge and opportunity for knowledge synthesis and also for science advice functions, which in Canada we saw really happen and mature through the pandemic. It's the first pandemic that we've had the benefit of a chief science advisor in place. And so I think that that'll be an opportunity.
I guess from my perspective, one of the things the pandemic has revealed is, well, 2 quick points. First, lots of rhetoric from some political leaders on the fact that they are, quote, following the science or, quote, just following the science. And we've done some research to try and track that in a somewhat systematic way. And the good news is it's uneven, depends on the country, depends on the politicians. The Governor of Canada did it a little bit at the outset of the pandemic, but less over time. And the reason that's important is because there's just a lot of research that shows that governments did not, and indeed almost never, quote, just follow the science for reasons we talked about a few minutes ago. And more importantly, they should not. That is to say that it would be somewhat technocratic to, if a government were to take that sort of approach. And so there are several chapters in the book that address this question, including a chapter by Catherine Frobeck at Dalhousie University, who contrasts the pandemic experience around COVID with our experience around the H1N1 pandemic, and draws on some collaborators who were in Nova Scotia to essentially draw this point that it would be odd if we had sort of deeply science-driven policy. But the other thing that the pandemic has shown, and again, unknown before, is there's no such thing as no monolithic science you can use to make policy. Rather, not only the science chain, as Sarah mentioned, I mean, that's in the nature of scientific research, but at any given moment in time, there are going to be dramatic disagreements between them, which is as it should be and is as sort of the science evolves. A few words, but if you work from the proposition that we should have evidence-based public policy, it assumes things about the evidence or about the science that are in fact highly implausible, particularly for something as big and complex as a pandemic.
Yes, I'm going to take a different tack on this question because our collective experience with the pandemic and understanding of the role of scientific evidence, I think our is also the general public's understanding of the role of science that has changed. With the pandemic, the first very, very obvious thing is that everybody realized is that with the same set of evidence, governments made very, very different decisions. So different policies in different countries, in different provinces, even in the same country. So this raised the question why, and as Patrick just said, it can be that governments are just following the science. So the context and intensity of the pandemic in one place can account for some of the differences, but not for all the differences. So it's put in plain sight that factors other than evidence explain the making of public health policy, and something that we all knew, but that has not been visible to the general public before. So the role of values, which I'm going to come back later, what is it that we really want to protect, but also the influence and the role of past policies and institutions. In some cases, the current state of infrastructure and public services was not able to absorb the increasing number of patients because of waiting lists, lack of personnel, lack of beds, budget, everything you know. So it also impacted on what could be done instead of maybe what we would have liked to do.
Thank you, Carole. So in public health circles, it's common to hear that public health policy is inherently political. What does that mean in practice? To what extent does the answer to that question vary between different actors in public health? So for example, university-based researchers, senior government officials. So Carole, maybe I can start this time with you.
Yes, certainly. So I hinted at my answer in my previous comment, but I think what it means in practice is that the decision to do something depends not only on the evidence, but on values and collective choices that we want to make for our society. What one society deems desirable or acceptable. From the same set of evidence, one could draw very different conclusions. And I'll take an example that is not pandemic related and not infectious disease related. If the evidence tells you that physical inactivity is bad for your health, what can you do as a government? You could focus on campaigns to raise individuals' level of physical activity. Or you could redesign the urban environment so that it becomes safe, easy, and quick to walk or cycle or take public transit. So you take very different decisions based on the values that you hold the dearest and the perception that you have of what a state should be doing. So citizens and governments' views on what's acceptable depends on something other than evidence. It depends on core beliefs about the role of the state, about their commitment to individual freedoms or to collective and societal choices. So it's political in that sense, in the sense that it relates to these collective choices. It follows, obviously, that there's a partisan dimension. Political parties have different values, and will draw different conclusions from the same set of evidence. You asked also if different actors in public health are going to have different conceptions of what to do or the role of evidence. I think different actors in public health also hold values and preferences that are not always the same, and probably more senior, something that we need to verify and research, but we are probably going to find out is that senior government officials have a very fine understanding of how political decision making works at all levels of government, and so they work so that evidence moves around and influences different actors involved in the policy process. My experience has been that university-based researchers, sometimes they're not as knowledgeable about the policy process and they are closer to their evidence.
Sure, I'll go ahead. Two quick points. When thinking about politics, it is common, particularly among public health scholars, when confronted with the fact that, to go back to where I was a minute ago, government doesn't in fact always make choices that follow the evidence, then in an effort to try and explain the variance, it's attributed to this all-purpose variable called politics, or in some cases, political will. So if the government is not doing what the evidence says the government should do, so the argument goes, it's because of something undefined called politics or a lack of political will. And if you search the term political will in the public health literature, it comes up over and over and over again. And when I first started thinking about this stuff, I asked myself the question, so what does political will mean? And in fact, it's not a concept that's routinely used in social science, because it's rather hard to measure. So any number of us would sort of get quite agitated when this concept came up. Scott Greer, who is a political scientist who teaches in the School of Public Health at the University of Michigan, took this on, and in the chapter he wrote for the book, he tries to unpack and make more operational, more practical or measurable this concept of political will. So it's not that the concept has no utility at all, but if it's going to be a useful explanatory factor for what governments do, or the lack of political will is going to be an explanatory factor, we have to do a much better job of specifying what it is that we mean. Because otherwise we're just sort of making a rather general reference. It's not much better than saying the problem is politics. Because as I once observed, when it comes to making public health policy, politics is actually not a bug, it's rather a feature. It's like software. Politics is, in a way, as Carole was alluding to, the way we manage normative disagreements. We all disagree on what makes for a good society and by extension, good policy. And the way we sort of manage those disagreements is this thing called politics. And public health is chock-a-block with such disagreements. And if the pandemic has shown anything, it's that those disagreements are real, and there are some minorities who feel very, very strongly about these things. And so people in the difference between different parts of the public health enterprise is that people in government know this. This is sort of axiomatically true, and much of government is organized to take into account these divergence of views. But one thing's for sure, we're not going to resolve these disagreements by simply piling on more science. So if, and this is not a particularly original observation, it goes back hundreds of years, but you can't get to an ought from a series of isn't. You can't come to an understanding of what ought to be done simply by gathering more evidence about what your preferred option, why your preferred option is better. People may disagree with your preferred option, notwithstanding the available science. And that's where politics, at least by extension, government comes in. So my hope would be that we get better at being plain and transparent about our normative disagreements, as opposed to simply hiding behind yet more science.
Thanks, Carole and Patrick, for your thoughtful reflections. I think the only thing I would add is that to really, I think, respond to this question requires a deep understanding of the policy process, and where science can and does fit into the policy process. The notion of having relevant and credible and timely evidence available when a policy window opens, and being able to knit that into cogent policy advice for that policy window. And so, we can't forget the pandemic responses, like any other government action, are human endeavors. They're led by people. And those are in different levels of government. And of course, they may or may not share the same objectives or how those objectives are best achieved. And I think Carole spoke to that really well.
Thank you, Sarah. So perhaps like never before, the scientific evidence that informs government public health policy, at least with respect to COVID-19, has been disputed, contested, and for a small but vocal minority, rejected outright. Governments must make decisions in the face of widespread misinformation and disinformation. How has this changed the ways in which scientific evidence informs public health policy? So maybe you can get us started.
Thank you, Vanessa. As I mentioned off the top, when this book originated well before the pandemic, and so little did we know that we would be, these questions would be quite as germane as they are. But I think we underestimate the shift that the pandemic has created, and we underestimate it at our great peril. It's not an overgeneralization to say that there was this assumption underlying a fair bit of public health policy that some combination of, in the face of a public health challenge, with be it communicable disease, infectious disease, non-communicable diseases, there was this assumption that trust us, we're from government, or trust us, we have these really smart science people working with us, and those two things combined will lead the way to what we need to do. Now, that was never sufficient, but it's most certainly not sufficient now, because the pandemic has not just underscored and revealed the fact that there are normative disagreements, but in some ways amplified. And so trust in government has taken a beating over the last 3 years. Trust levels are falling. People are increasingly disaffected. Large numbers of people are increasingly disaffected. And so the challenge of policymaking in public health policy in other areas is greater than ever before. And so it strikes me that the public health enterprise is going to need to do a better job of figuring out ways to make public health policy that's both informed by the best scientific evidence, but also enjoys a degree of democratic legitimacy. And so this is a common theme through many of the chapters in the book. So Adele Casolo, one of my co-editors, was the lead author on a chapter in which we survey the devices that exist around the world, whether these be code development, citizen participation in research, whether it be citizens fora, various kinds. And we go through systematically the advantages and disadvantages of each. And there's one chapter in particular by Kat Smith, where she reports on some work done in Scotland, where they experiment with deliberative fora, sort of democratic deliberative fora, to try and figure out, is there a way in which you can bring the best available science and the public together to try and wrestle with the inevitable challenges and trade-offs. And so these kinds of tools are probably going to become more rather than less important, because I don't think we can, what we would have done 4 or 5 years ago isn't going to be sufficient unto the day, simply because I think people are much more alive to these disagreements. And to put it quite bluntly, 3 or 4 years ago, most people, when asked, would have had either no opinion on this thing called public health, or they would have probably thought it was kind of a good thing. We have to grapple with the fact that for some, public health is a controversial thing now, right? Or whether they're right or not right is really beside the point. That group of people needs convincing in a way that they never would have before, and this is a fundamental challenge. So collectively, we're going to up our game when it comes to making public health policy.
Yeah, I think that Patrick's some really interesting reflections. I guess I would offer a couple of others. So the first is around science literacy and just the basic science literacy of the public, of the politicians, and also of policymakers, I think has really increased. I think there's still some room to improve. Patrick spoke earlier around the fact that science, of course, is not static. It evolves, that basic understanding that science is a process. Also that, the findings of a single study need to be situated in relation to a whole body of literature. there's some really interesting data looking at how quickly individual studies are picked up in press releases and on social media very, very quickly after publication, which doesn't allow time for that broader synthesis, of course. The other is around understanding the concept of uncertainty and the fact that there are some things that we don't yet know. And so, you know, the quality of evidence, the strength of that evidence, and how certain we are, how confident we are in the findings across multiple studies, I think is a really important concept as well. So science literacy would be one. Public health literacy, which I think Patrick, you know, just spoke about, is another. We've had a huge growth in people understanding what is public health. I used to say that I worked in public health. People were like, what is that? Now people understand, people in my immediate circle, you know, my mother, my cousins, people that are not at all connected with public health, they get it now. They understand the impact in people's everyday life in a way that they didn't previously. And I think that's powerful. It's also a privilege. We need to, you know, maintain, as Patrick said, trust in institutions. And I think the movement of mis and disinformation is really an important exercise in understanding around how to establish and then also maintain trust, not just in science, but in the institutions that are responsible for public communication. And certainly as a public servant, I think about that a lot. And my role in that translational space.
Thank you, Sarah. Carole?
Thank you. I'll follow on Sarah's comment about trust, because the line that I chose to answer this question is to take a look at legitimacy. Patrick said this morning in another presentation that a lot of what public health does is geared at changing how individuals behave. So they need to trust the voice telling them to do things differently. But they also, I would add, need to convince decision makers to change policy, to change the natural environment or the built environment so that it improves the health of populations. So a lot of what public health does is building its legitimacy to become credible in the eyes of the public, of the general public, and in the eyes of other decision makers that have the resources to make life-changing decisions, such as increasing minimum wages or increasing services for the most disadvantaged. So in a context of misinformation and disinformation, building the legitimacy of public health can depend on its perceived proximity to elected officials, to the government, to the Minister of Health, just as much as an evidence. So is public health independent enough, autonomous enough? And maybe this connection explains why in Quebec at the moment, there is a lot of discussion about the governance of public health. How should public health be directed from the top? Should the medical, the chief medical officer of health be independent, be the same as the chief of administration? There are big debates about this at the moment. So really, I think legitimacy is key to public health action and to its capacity to act. And it's difficult to establish legitimacy in general. It is difficult, especially I think in the context of a pandemic, because of all the misinformation and disinformation, which is not just about the pandemic, but also the rise of right-wing populist governments a bit everywhere. So
thank you. So our final question for the evening, in a public health emergency like COVID-19, the available scientific evidence is constantly evolving. Not surprisingly, the scientific community often disagrees on what we know or the quality of the research that is available to inform government policy. What options are available to governments on how to manage this uncertainty if not outright disagreement. I'm going to get Sarah to begin. I'd also encourage folks who are on Zoom, please do put your questions into the Q&A. We'll have some time to get to those once our panelists wrap up this final question. So, Sarah.
Sure, thanks very much. And here I'm actually going to point to the Global Evidence Commission work that I think has done a really beautiful job in synthesizing experiences and evidence globally around how evidence support systems can be improved, what the pandemic has taught us about how evidence moves or doesn't move within systems, and what's really needed to have world-class evidence support systems across public and other institutions. And, you know, there, I think that they do an excellent job drawing on some of the key ingredients based on those lessons, including having integrated science advice structures, having evidence syntheses not just be static, but living, ensuring that evidence is well connected to the context into which decisions will be taken, so that there can be some meaning making associated with the evidence findings, and that the understanding of the complex evidence base that it does make up, well, in our case, public health, comes from different disciplinary perspectives with different methodologies and different paradigms that are influencing how that evidence base is constructed. And there are ways of putting that together, you know, in a way that helps policymakers understand the strength of the evidence that's being looked at, confidence in the recommendations that are coming out of that evidence base, and then tying them to the vision.
Well, if I could just pick up where Sarah left off, one of the odd patterns of the last couple, 3 years is that the public, the media, and occasionally governments have given voice to all sorts of people who claim expertise. And much to the chagrin of public health leaders, we live in a world in which if you have doctor in front of your name, not PhD so much, but medical doctor, that qualifies you to comment on public health policy. Sometimes that's true, but sometimes that's not true. And so we have to be much more sophisticated and give the public health expertise its pride of place, because public health is just as specialized as surgery. You wouldn't ask an epidemiologist to comment on surgery, but the reverse is also true. And so we need to get used to the fact that this expertise is not evenly distributed as it were. But the other thing that's important here is we also have to not be naive. Lots of arguments are being brought in the public square around the pandemic, and indeed around public health policy more generally, that are being advanced by people who have something to gain or something to lose. We learned through the tobacco wars that big tobacco had figured out that if they can cast their argument and wrap it in science, that will get credibility. Nothing's changed, right? We know that to base my argument on science, it gives my argument a certain currency, and we need to be critical in a metaphorical sense. We need to constantly ask ourselves the question: well, just because that person is ostensibly an expert, and maybe they are, but what's the sort of normative position they're trying to defend? And so the pandemic has been full of people, and I alluded to this earlier, whose real concern is they believe that governments should not limit individual freedoms in the way that they do during a pandemic, which is an absolutely defensible position on normative grounds. But they wrap it in a bunch of science, and they say, well, it's very clear that the evidence shows that blah, blah, blah. So it's very easy to find, for example, people who will argue, oh, the evidence is clear. Closing schools is bad for student outcomes and blah, blah, blah. That issue is not going to be resolved on an accumulation of science. That issue is because we just disagree as to some relatively basic questions. Same things holds true for lockdown, same thing holds true for mask mandates or vaccine mandates. So it's not the amount of science that is going to make a difference. I guess the other thing I'd say about this, though, is we actually know a fair bit about this. Over a number of years, a bunch of people have given this a great deal of thought. And so several years ago, Justin Parkhurst, who is a professor at the London School of Economics and Political Science, published a great book, which is essentially around the concept of the good governance of evidence. There are techniques, tools, and things that governments can do, and Sarah alluded to several of them, to ensure that the evidence that is brought is appropriate, timely, et cetera. And the single biggest message that I always, when I think of that line of argument, is transparency. If we've learned anything through the pandemic, it's that if we can maximize the transparency of the science that's brought, and we've done an amazingly good job of that overall, public confidence will go up. But we still have a ways to go. And so if you'll allow me to get a little nerdy and a little technical for a moment, around the country, a bunch of people want to know, well, what evidence, what was the advice that the government used? Or what was the science on which the government based this decision? I want to know, says the person going into the public square. And indeed, government's been taken to court and required to reveal either the advice or the science or both. We have in Canada a longstanding convention that says that the advice proffered by the public service to government is confidential. And there are people who we can argue both sides of that, but no one said that the scientific evidence that was gathered in order to formulate that advice necessarily needs to be confidential. So there are tools that we can use and experiments that we've done that can provide some transparency on that science. And so, for example, here in Ontario, we had the science table, which was an arm's length autonomous group of people who came together. In the UK, they had SAGE and then Independent SAGE, which were committees designed to do something broadly similar. What will matter going forward is, now that the science table is no more and it's been folded into Public Health Ontario, is can we still reassure the public and be transparent about the science that is feeding into government decision-making? And in Ontario, that would be Public Ontario. In Quebec, it would be the NSPQ. In BC, it would be BCCDC. So we have institutions whose job it is to bring the science together. And we have to be very vigilant and very good at being transparent about that, so that the public has confidence that the decisions are in fact informed by the best available evidence, but also as a counter to those who would say, well, I have a study that shows X, when in fact they're essentially making a normative argument as opposed to a scientific one. So I'll stop there.
Yes, absolutely. One thing I didn't say and should have, and Patrick's remarks certainly made me think about, we've talked about science, we've talked about public health policy. We haven't talked about science policy as an instrument in this landscape. And I think it is worth rounding out my remarks by noting some of the science policy instruments that have really enabled hardwiring some of how science advice is situated within decision-making, as opposed to, leaving it up to individuals. So I mentioned early on the scientific integrity policy that we have in place, which enshrines scientific advice as part of our integrity work within the Public Health Agency. I'll also note the Chief Science Advisor's Open Science Roadmap and our Open Science Action Plan within the Public Health Agency of Canada. And I'm mentioning those because I think they're good examples of how science policy instruments can actually help make and enable greater transparency of science for policy. And so thanks for making me think about that.
Carole, we'll turn to you for some final remarks.
Right, very quickly, going back to what Sarah and Patrick have talked about, I really agree with the importance of transparency in science, and with the fact that, as Patrick said, public health is an expert community. I would just like to add that it's a very diverse expert community. So some of public health is more into epidemiology, while others are maybe going to be community psychologist, for instance. So each discipline within public health is going to come with their own interest and maybe their own ways of making science. And we need to make sure we have room for the different kind of evidence, not necessarily more evidence, but different types of evidence, and to go back again to another comment that Patrick made, and another theme that is that comes back throughout the book, the importance of consulting with groups, with stakeholders. I think it's another way to collect evidence when there are not yet studies to be included in systematic reviews. And really several chapters point to the importance of participatory policymaking. And I think it's a tool to manage uncertainty as well.
Thank you, Carole. Okay, so we're going to open it up for some Q&A. So Giles, the lovely Giles, has a mic here in the room. So if there's any questions, please feel free, raise your hand. It would be great if you could introduce yourself first, if you're comfortable, and anyone want to get the ball rolling here? And there's Giles in the mic. Anyone in the room? If not, there's a few questions. Oh, there we go.
Hello, thank you. I'm Natalie Brender. I'm Director of Policy at the Canadian Public Health Association. I'm glad Carole raised at the end this point about how there are, if you want to say, different types of evidence or different sources and different kinds, because so much of this discussion seemed to proceed as if there are two relevant factors in government policy making, either the scientific evidence and the norms. But from what I'm seeing, you know, in the context of how the directors and policy analysts within the organizations in the public health ecosystem are proceeding, a huge and rising input is the factor of lived experience and the testimony of communities, and whether Indigenous or Black Lives Matter, or the perspective of drug users or sex workers. From where it looks within my section of the public health universe, you know, that is as much relevant evidence to be considered as anything else. And there are much harder issues than the pandemic, to be honest, when it comes to integrating these considerations. The opioid pandemic is a much harder field to sort out whose perspective should count as authoritative and who has expertise. So all of which is to say that, of course, it's important to discuss the learnings for the pandemic, but there are issues where evidence is so much more fraught and so much tangled up with who has evidence and expertise and standing, and how this interacts with the norms at play.
You to start off, Sarah?
Yeah, thanks. Thank you for being explicit about what is implicit in some of what I've said. I think that's really important. Public health has a history of participatory action research that is long across a variety of areas. And that includes having, I think it's
oh, now it's loud and proud. It's certainly, you know, I sort of grew up working in the field of tobacco control. And one of the things we didn't do very well, actually, in that field was integrate the perspective of those that smoked in tobacco control policy. My first foray into public health was through youth advocacy and engagement on tobacco control issues, because at that time, youth were the highest smoking population in the country. And there were few mechanisms for youth to be the experts on youth. And so your points around that kind of integrated living and lived experience perspective into the public health evidence base, I think, is critical. Dr. Tam really explored this within her report last year, where she articulated the principles underlying a world-class public health system, and being participatory and equity-driven and oriented were really core. We also didn't really talk about multiple sectors. And of course, you know, the NGO sector is really critical. And so I'm glad that you identified as being from the Canadian Public Health Association. And I'd love to hear how you integrate science in your policy position documents, because I think that's another part of the evidence pipeline that influences decision making. Thanks for your question and point.
Natalie raises a very interesting and very tough question. Just as science is not monolithic, nor is public opinion. So one thing you don't want to do in situations like this is assume that if you want to know how to ensure that your policy choices are maximally responsive to public concerns and public needs, is to rely on the traditional mechanisms of doing so. So what do we traditionally rely on? Well, we in a representative democracy, we elect people and we expect them to speak on our behalf. And we also rely on various forms of public opinion polling where we'll survey the public. But we know that there are certain voices that are systematically not included if that's what you rely on. There are various minorities whose voices never heard when you do that. This is well known and well understood. The million-dollar question is how to overcome that. The good news is we learned a few things during the pandemic. So there were natural experiments in Toronto, Montreal, Vancouver, and elsewhere, where sort of observing that rates of vaccination were low among certain communities, people spontaneously got themselves organized to try and reach those people. So that's more from a service provision point of view. But from a policy provision point of view, we do, again, in the book, there's a couple of chapters that deal with this, in particular Cat Smith's. We do have tools that are used outside of public health policy that are used precisely to go and get those marginalized voices who might not otherwise be heard. I'm not comfortable with, characterizing it as what weight to give them. That strikes me a little bit zero sum, but it is critically important that we make sure that our processes are as inclusive as possible. And we learned that big time during the pandemic, when we discovered early on that certain racialized minorities in big cities were being particularly hard hit by the pandemic. And we did not have a systematic way of knowing that and acting accordingly. And we learned along the way. So I think we need to codify those lessons and act on them going forward.
Carole, do you have anything to add? No? Okay. Any other questions in the room? Yes.
Oh. Hi, I'm Colleen Flood from the Faculty of Law, and wonderful to be here, and congratulations, Patrick, and the team on the book. So I had two kind of thoughts, questions. One was about the lessons learned, Patrick, and I guess this is really for everyone in a sense. We probably can debate the heck out of what those lessons actually are, but assuming we come to some kind of consensus about that at some point, I think, what we've always lacked is implementing those lessons and making sure that we are better prepared for future public health threats and pandemics. So how do we go from lessons learned? I think we can actually do that, to implementation, given what we know about people's mindsets and wanting to move on and, kind of play down now the what has happened and just get on with life kind of thing. So I'd love to hear what everyone has to think about it. And then the second question I had was just some musings about transparency. And, I'm with you in the prayer book there, Patrick. But I wondered a little bit about this on the transparency front, with the difficulty that folks have had, I think, communicating the changing science, the evolving science, the fragmented science, the unclear science. And although we say that transparency is important, I'm not sure that the public have reacted to it as well as we might want. And so, you know, you see people saying, you know, the vaccines are a failure, you know, they didn't cause sterilizing immunity, you know, you told us they would do that, and then you said they wouldn't. And so, you know, they're this and that and the other thing. So and to me, you know, that was the appropriate thing. You know, then we needed to be transparent about that. We need to communicate that. But I'm not sure what the answer is, but we lost the public somewhere, or some of the public anyway, along the way. So the transparency and the comms side of things, I guess I'm just love to hear your insights, Patrick and others, about how we navigate that.
Only slide can be relied upon to put a lot of stuff on the table all at once. These are tough questions. So let me deal with the first one. And I'll take your assumption that we could codify lessons learned, although that probably is going to be harder than it might sound. And how can we ensure implementation? Lots and lots and lots of discussion of, did we learn the lessons of SARS? And if not, why not? Blah, blah, blah. So let me make give a concrete example of what we don't want to do. So based on some of the research that I'm doing, coming out of SARS, one of the generalizations was, we need to give and strengthen, we need an independent and reasonably autonomous voice for public health. So we need to create Public Health Ontario, and we need to ensure that the chief medical officer is enjoys a degree of autonomy, which is true. But it's as if the McGuinty government had never met anyone with expertise in political science, because the device they came up with was peculiar, is the nicest thing I could say. So it sounds great. Let's ask an all-party committee of the legislature to name the chief medical officer of health, and thereby link the chief medical officer to the legislature, and thereby, so the argument went, give this person a degree of autonomy and democratic legitimacy. Sounds good, but if you think about it for a few minutes, it doesn't work. And of course it doesn't work, because this person's role enjoys no ongoing linkage back to the legislature. They are a public servant in the normal way, and it had no appreciable effect. So absolutely, we need to learn the lessons, but in so doing, we need to think more deeply about public health governance and make sure that the devices we come up with are robust and reflect what we know about actually the way government works. I guess the other thing I would say, and here allow me to editorialize, several provincial governments have already said they're either not going to hold a public inquiry, or the inquiry they've announced, as in BC, is extraordinarily narrow. This is both tragic and odd. It's odd in the sense that something of this magnitude, you would think that there would be a fulsome inquiry, but Colleen, you alluded to it. There's a psychological desire, collectively, individually. Can we just move on to something else, please? But it seems to me governments can't do that. Our governments have an obligation, it seems to me, to ignore that and forge ahead. So last week, Minister Duclos made reference to that there shall be an inquiry, and I took that. I'm very glad to hear that that's true. But I am distressed that several provinces will not, or their inquiries will be incredibly narrow, or in the case of New Brunswick, they're forging ahead and making changes as we speak. This is not good, because we risk making the wrong choices and to our collective detriment. But it may take many years. A challenge of this magnitude is not going to be processed, probably in my lifetime. As to your second question, it's a tough one. But since this is a panel based on this book, let me do an infomercial for political science. You can simultaneously take the position, as I expressed in response to Natalie's question, that we need to go out of our way to bring all publics into the conversation. But nor do you necessarily treat all those public inputs as being of the same character. Not that one is better or worse than another, but they're not of the same character. So yeah, absolutely. There's a whole bunch of people who don't understand the way science works, and maybe it would be too much to ask them to. I mean, maybe that's asking too much. But for those people, it seems to me you listen carefully and you say, okay, you don't understand actually the way science works, but what is it that you're really concerned about? And there are any number of tools and devices. But conceptually, we just make a difference between the different kinds of public inputs, and we process them differently. And so you have a public meeting that is open to the general public. That kind of conversation looks very different than when you invite the 5 or 6 smartest epidemiologists you know into a consultation with the minister or the deputy or whatever. So we do engage publics in a variety of ways, and we have to do that on an ongoing basis. But I guess the final thing I'd say is, and again, back to Justin Parker's book, the good governance of evidence accepts that it's going to be messy. It just accepts that that you shine a bright light on it and it doesn't achieve consensus. But the alternative is worse, right? And so all you can do is make things as transparent as possible. And I guess then the final thing I'd say is, and I don't know, I'm particularly preoccupied by this, but we also need to ask, when someone comes to the public consultation and challenges, we need to always ask, so challenging based on what concern, right? Because there are going to be those who have views on the appropriate role of government in our lives, and that's fair game, and that's appropriate. And I guess the final thing, just because I'm in a grouchy mood, what we don't want is to allow the media or politicians to try and amplify those disagreements, right? We're much worse off if we allow our governments to amplify the things that we disagree about. It strikes me the job of government is to try and bridge those gaps. Because this conversation is going to be ongoing. And if we start off right out of the gate amplifying the things we disagree about, we're not going to get very far.
Carole, do you want to weigh in?
Yes, very quickly, going back to Colleen's first question, how do we go from lessons learned to implementation? As a political scientist who studies the implementation of public policies, I know it is something that we don't do that often, or maybe there is not enough in general. But in the case of the pandemic, I think my particular fear is that we are going to behave as if changing some rules, changing some norms, changing organizational structures, les organigrammes, it's going to solve the problem, and that we can forget about the power relationships that are going to be inhabiting those structures. But the truth is, we can't forget about those power relationships. Public health seems big at the moment because it's been everybody's focus for the past 2.5 years. But when things go back to normal, other interests in health policy are going to be fighting for the biggest part of the budget or the biggest influence, and professional organizations like les ordres professionnels, syndicates of doctors, they're going to be much more influent than those representing public health officials. So we're going to go back to this imbalance of power in favor of probably healthcare rather than public health. So changing institutions and rules is going to maybe to change some things, but it's not going to change everything. And implementation, therefore, is going to be a major challenge. And the last point, I was reading again Catherine Frobeck's chapter this afternoon in preparation for this panel. And she says, well, we don't want to study something that's not happened already or that's not happening right now. So I think maybe we're going to want to forget the next pandemic and think about something else. So that also is going to be a challenge for implementation.
Just a couple of thoughts to add on. Around lessons learned, I think it's really important to consider the reference points. So what does a successful pandemic response look like? Is it around health outcome metrics? Is it around having followed the plan that was laid out prior to the pandemic? What's that reference point? The other is around the time frame for those lessons. So is it where we started in January or earlier 2020? Or is it how lessons have been integrated through the pandemic? Because I don't think that it would be appropriate to think that lessons haven't been integrated and implemented in real time. And that I can assure you has happened, at least at the federal level. And so that would be another, I think, dimension. And then the third that I would note is just around lessons from whose perspective. And I think that the point around power and voice and whose voices are represented in the understanding of lessons learned are really critical to take into account. To your point around implementation, I think it's really brilliant. I mean, there's the assessment of the lessons learned, and then there's the assessment of the capacity at the individual, organizational, or institution and system level to actually implement those lessons learned. And I think that if we're talking about building back better, building back a public health system that has in place, all of the necessary ingredients for the kind of response that we would consider a success, what are the competencies that we need to have in place to actually do that? And what's the resourcing picture, as was noted by Carole and Liz? To your second point, I guess I would just add by noting that, of course, there's a science to science communications, and I think there's a lot to be learned there, and risk communications and behavioral science and many other areas that can help us understand that. And that's an area that the Public Health Agency has grown during the pandemic, and hopefully we'll see continue to be fostered long past. And you've got the head of that sitting to your right, left, I'm not sure which, but he's nearby. So he'll have some thoughts on that too, I'm sure.
Thank you. I think we had one final question in the room, and this will be the last question. Thank you.
Hi there. My name is Laura Burton. I'm a dietitian by training, worked in population health, but I'm back here doing a master's. And you might have touched on it. I came a little bit late because of class. I apologize. But just thinking about and reflecting on your conversation about trust and how we kind of build in, trust for the institutions, trust for the messages. And I think it's kind of twofold. One, inequality is sort of built into our systems from, the young age. We separate kids into kids who are bound for university, kids who are not, where kids go to school matters, those sorts of things. And so how we support the general public in trusting these institutions that potentially have caused that mistrust or oppressed them for different reasons on one side, and the other side of trust in kind of reckoning with, our sometimes in public health focus on behaviors and how we've relied on, frankly, weak evidence to sort of give messages around body size or what to eat and those sorts of things. And so I'm just really curious from the panel in terms of if we're building back how we kind of build trust into the policy that we make and the messages that we send everyone. Thank you.
Laurel, thanks for that. We've sort of touched on this indirectly in a couple of ways. So how to build trust. First of all, trust is a many faceted thing. So trust of whom? So your question was mostly in the context of the general public. So I think that I've mentioned already a couple of things that we can't rely on. It's not going to be sufficient to say Trust us, we're from science and therefore we know. You alluded to some of the reasons why that won't work. And nor is it going to be sufficient to for governments to say just trust us. But again, we have a bunch of tools that we can use. So I've mentioned transparency. Another tool is accountability. So one of the odd characteristics of public health policymaking during the pandemic is because it all happened incredibly fast, the normal feedback loops didn't necessarily apply. And so, for example, Parliament did not meet for several months in a row. And so public trust is enhanced if people think, gee, I'm concerned about this, or I didn't like that decision. If people can see that there's a feedback loop and their concerns are being aired, then that can, in the long term, engender a certain amount of trust. Alas, that's not happening very well, and it varies by jurisdiction. It varies from one province to the next. Second, we need to hold all of the actors accountable and allow them to explain themselves, as it were. So, for example, in Australia, at the state level, in Victoria and in New South Wales, I think I have that right, the chief health officer, as it's called there, is required by law to appear before a committee of the legislature to give an account of the advice they proffered to government. It's not magic. It doesn't make a huge difference, but it's you have to just pile example like that after example so that we require of the people who are making these choices on our behalf to give an account of what they did, and then we can have a conversation about whether we think what they did was good, bad, or indifferent. The final point I'd make, and this is the hardest one of all, is the people who are most affected by the pandemic are frankly none of the people listening to this webinar or in this room, right? We have all the evidence we need to show that the people most affected are the most disadvantaged among us. How we go and maximize and regain their trust is a much bigger challenge. And in some ways, we never had it, right? Because we have certain numbers of people who are disaffected from the political system. This is critical going forward. Because here's the thing about infectious disease, unlike in a number of policy areas. To be maximally effective, you have to get participation rates that are extraordinarily high. There are a few areas of public policy where you have to get quite so many people to agree that that's a good thing to do. If you don't like what the government's doing on something, you can just ignore it, right? For the most part. But vaccination and masking, it's not quite like that. And so it is a particular challenge in public health. We can't just pretend that those people who are disaffected or aren't paying attention or disagree aren't there, because we actually need their active cooperation. So in a way, it puts public health on the bleeding edge of the ways in which we engage publics in all of the diversity. So I can name the problem really well. I'm not so sure I'm good on naming the solutions, but it strikes me that it's something we have to deal with.
I'll do it, Carole.
Yes, just
Anything to add?
a quick word to follow up on Patrick's last remark. He said we need high rates of participation in things like vaccination, for instance, to be efficient. And how do we gain that? And I think there's some kind of paradox. We need high participation from a high number of people, but in order to get to them, maybe we need to engage them individually or in small groups. And that's been shown to work during the pandemic, to go where people are and let them ask questions, and go in a park with the mobile vaccination clinic, go in a church in a disadvantaged neighborhood. All things that have been done in Montreal and that have been effective at reaching a few more people and making them get vaccinated. So it's a collective enterprise, but it also requires very personal relationships between public health and all those publics.
just to follow up on Carole's comment, public health from its very beginnings, much of the heavy lifting is done at the local level for precisely the reasons that Carole states. Much of the innovation in public health has always happened at the local level. So it's unrealistic to ask the government of Canada or even provincial governments to systematically go where the people are, as Carole describes. But local government does have that ability when it's operating at its best. And so it's a reminder that the structure of public health governance, it is decentralized and it is local for a reason. And in fact, it potentially is one of the strengths. The trick is how we maximize the lines of communication upwards and downwards from the local to the regional to the provincial and to the national and beyond. But it strikes me that if we're going to go and regain that trust, Carole is absolutely right. It has to, our local actors need to be part of that conversation.
I'd like to thank all of our panelists this evening for their fascinating responses to some really difficult questions. And another hearty congratulations on the book, Patrick and Carole and team. For folks who are here in person, we've got a little informal get together. And for those of you who joined us online, thank you very much. Have a great rest of your evening. Thanks, everyone.